Infection. Syphilis. Nature. It is a venereal disease caused by a spirochete, Treponema pallidum. Decreased incidence in the second half of the 20th century due to effective antibiotic therapy. Recent incidence increased due to promiscuous sexual practice. Etiology. The spirochete Treponema pallidum is present in large numbers in primary and secondary lesions of the acquired syphilis and in lesions of congenital syphilis. Treponema pallidum microscopic picture. The mode of infection. Through intimate sexual contact with a syphilitic patient. In congenital syphilis, the fetus is infected by transplacental spread in the late stages of pregnancy. The incubation period, 3 to 6 weeks. Primary syphilis clinical picture. Chancre, painless regional lymphadenopathy. The chancre. It is fair, round, small, painless genital and painful extragenital, and it is slightly raised. The genital chancre painless. The extragenital chancre painful. At the site of inoculation, surface ulceration with thin serous exudate. Heals on its own in 6 to 8 weeks with light or no scar. Progresses to the secondary stage if not adequately treated. An infiltrate of plasma cells, histiocytes, and lymphocytes present. The findings are non-specific. Combination of endarteritis, plasma cell infiltrate should point to the diagnosis. The microscopic picture of a chancre. Lymphadenopathy. Painless enlargement of the regional lymph nodes. With genital chancre, they are discrete, elastic, mobile, and painless. With extragenital chancre, very marked enlargement, discrete and fleshy. Secondary syphilis starts 8 weeks after infection, lasts for 6 months to 2 years, disappears spontaneously. Toxic signs and symptoms. Generalized lymphadenopathy, skin and mucous membrane lesions, splenomegaly is occasionally present. Toxic signs and symptoms in the form of anorexia, fever, and anemia. Generalized lymphadenopathy, slight, characteristically the epitrochlear lymph nodes are affected at the elbow. Generalized lymphadenopathy and the epitrochlear lymph node. Skin and mucous membrane lesions. Skin lesions are bilateral and symmetrical, may be macular, papular, follicular, papulosquamous, or pustular lesions. They are seldom pruritic. Skin lesions are bilateral and symmetrical. Syphilitic skin lesions, follicular, pustular, pustular, papulosquamous, and macular. Papular squamous eruption at the palms. Papular squamous eruption. Feet. Pink macules at the wrist and the foot and the feet. Non-pruritic skin rash. Usually dry. Vesiculobullous lesions don't occur in adults, but may be seen in neonatal congenital syphilis. The lesions in a baby of congenital syphilis. In secondary relapsing syphilis, lesions tend to be arciform or archiform and may be asymmetrical. Moth-eaten scalp alopecia beginning in the occipital hair is characteristic. Most papules occur most frequently in the anogenital region and the mouth. They are called condylomata lata, but they may be seen on any moist body intertrigonal surface like the axilla or the toe webs. Condylomata lata. Condylomata lata. Mucous patches of the mouth, throat, and cervix dry. Mucous patches. Penile mucous patch. Occasionally, secondary lesions occur while the chancre of the primary syphilis is still present. Splenomegaly is occasionally present. Tertiary syphilis occurs after 2 years. Manifestations: localized gamma or diffuse gammatous infiltration. Gamma is a firm, round mass, enlarges slowly, softens at the center, superficial gammata ulcerate, forming gammatous ulcers. Gammata. Diffuse gammatous infiltration is less common and occurs chiefly in the bones, joints, meninges, and testes. Diffuse gammatous infiltration. Gammatous ulcers. Gammatous ulcers are circular, have circular outline, punched out edge, undermined base, wash leather slough at the floor. Separation of the slough leaves deep ulcer with bright red granulations. The ulcers heal and break down again. Gammatous ulcers. Congenital syphilis. Congenital syphilis is of little surgical importance. Investigations. Dark ground illumination to demonstrate the organism in the exudates and body fluids. Immunological tests, specific and non-specific. Non-specific immunological tests, Wassermann reaction, Cohen's test, VDRL, venereal disease-related lesions. May be false positive results with malaria, glandular fever, leprosy, collagen diseases, or chronic liver disorder. Specific immunological tests: Treponema pallidum hemagglutination assay test, TPHA. Treatment: penicillin is the drug of choice. Penicillin G 2 to 4 million units intramuscular in one injection. Erythromycin or tetracycline may be used in penicillin-resistant or hypersensitive patients. Oral erythromycin 500 milligram 4 times per day for 15 days. Good luck and best wishes.